Hello, everyone, and welcome back to Karan Academy. My name is Karan, and today we're going to be talking about benign prostatic hyperplasia. Now, BPH is one of the most common conditions you will encounter across your career. It's one that you should understand super, super well. Now, whenever BPH or the prostate ever comes up, the biggest concern on your mind and the minds of your patients is going to be, oh, is this cancer? So being able to continuously distinguish BPH from prostatic cancer is super, super important. And I'll be talking about this distinction both throughout this lecture as well as our next lecture, which is on prostatic cancer. So what is BPH? So you need to know that it's a non-neoplastic proliferation, so it's non-cancerous, and that it traditionally happens in the transitional zone of the prostate. And this is really important to know. You also need to know that it's super, super common, and a good way to remember it is that the prevalence is usually corresponds with the age. So 50% of 50-year-olds have BPH and 80% of 80-year-olds have BPH. So what is actually happening and why do people get BPH? Firstly, you have androgens like DHT, particularly dihydrotestosterone, which is produced from testosterone. And DHT is a potent prostatic growth factor. What this means is the DHT levels cause proliferation or growth of the prostate. Now, some people have a natural susceptibility to these DHT receptors, and therefore they will require lower amounts of DHT to cause growth and hyperplasia. And this is why we often see a genetic link with BPH. You also need to know that estrogen levels play a key role. And a common question you'll get asked is, well, why does this prevalence increase so rapidly with age? And the reason for that is the estrogen to androgen ratio and its imbalance, which has a role in BPH. So with age, as your testosterone levels decline, your estrogen levels tend to still remain relatively stable because these are obviously going to be in much lower quantities, but they stay relatively the same. Because of this, you see a much higher estrogen to androgen level, and this contributes to the development of BPH. Very, very important to know that BPH doesn't increase the patient's risk of prostate cancer, because that is going to be the biggest thing on their mind when they come to you with anything, including the prostate. So really, really important. I usually don't go over a bunch of anatomy, but this is really key, and it makes everything so much easier. So let's break down the prostate. So as you can see, the part in green here is the prostate. If you break this down, we can broadly see three different zones, or four, but three relevant ones. You have the central zone. This is the seminal duct, or the ejaculatory duct. You then have the bladder here. You have the urethra in yellow. You have the transitional zone, which is in green, and you have the peripheral zone in blue. Now, what we just said is that BPH affects the transitional zone. If I were to tell you that prostatic cancer affects the peripheral zone, you can kind of piece together how they would present and why this difference exists and is important. Because BPH affects the transitional zone, and that is the part that's very close to the urethra, you are going to compress the urethra with BPH quite commonly, right? And that is why we get a lot of the lower urinary tract symptoms of BPH. So what is going on here? Firstly, instead of going through a list of clinical features, let's make sense of it. You have hyperplasia, and this is basically grown in size, and that's going to start compressing on the urethra, right? Because the urethra or the tube is now compressed, or the bladder outlet is now compressed, you end up with something called bladder outlet obstruction. Makes sense, right? You have the bladder outlet, and that's obstructed. Firstly, it's going to be hard to start peeing because this is blocked, and opening that up is going to require significant pressure. That is called hesitancy. You're also going to have straining, or the tendency to strain to be able to pee. And this is because the transitional zone, which is now undergone hyperplasia, is going to be compressing on that urethra. Once you start, it's also going to be hard to have good flow, and that's poor stream. And urination may also be difficult because of many of those factors. So you're straining, it's hard to pee, The lumen of the urethra is quite compressed. All of this presents in this particular way. Then again, your bladder is a big reservoir, which isn't being emptied as effectively because, as we talked about, its bladder or its outlet is being obstructed. Because the outlet is obstructed, you will often see incomplete emptying, right? So you're going to have incomplete emptying. You might have piss on dough where you feel that you've gone, but then you haven't, or you have a tendency or a desire to go again. You can also end up with urgency. The reason you end up with urgency is because once you've obstructed the urethra, the bladder is going to fill up quite a bit. And then all of a sudden, it's going to trigger that response, that reflex arc that makes you want to go and pee, which is why you get a sudden urge, and that's urgency. You can also get hematuria because as you are expanding the bladder, you can have micro damage to the vessels that are quite superficial. And this will present with hematuria, although most cases would be microscopic. So let's break this down again into the two types. So we have irritation and then we have obstruction. Irritation of the bladder going to present frequency, urgency, nocturia, and obstruction going to present with piss, poor stream, piss on dough, dribbling. Makes sense so far. So think of it that way. What would you find on clinical examination? So when you perform a DRE or a digital rectal exam, you will find a symmetrically enlarged, smooth prostate. Again, reiterating that during the digital rectal exam, you are going to be running your finger along the posterior aspect, right? And that is not going to reveal a nodularity because there is no nodularity. The transitional zone is just enlarged. That's the origin of it. And it's going to be smooth. So what investigations do you consider? Well, you would like to do urinalysis because especially in old patients, never ever rule out a UTI. Increased frequency, voiding, piss on dough, hesitancy can all be features of a UTI as well. So you want to always rule out a UTI. For that, do urinalysis. Perform blood sugar level tests, especially if the patient's diabetic. For bloods, you can do an FBE and UEC. A UEC is important to assess renal function because with the obstruction of the urethra with prostatic hyperplasia and expansion of the bladder, that can often result in backflow of urine to the kidneys, causing hydronephrosis or a post-renal AKI as well in some cases. And we always want to monitor the kidney function to ensure that there hasn't been damage or a drop in their eGFR. A PSA or a prostate-specific antigen level, as well as a free PSA, and we'll talk about the PSA in a bit. In terms of imaging, we can do urodynamic studies. All that means is that we are performing an ultrasound to look at the measurements of the bladder, to look at how quickly they can release urine and so on. You can do an ultrasound of the prostate, which can be either from a pelvic approach or from a transrectal approach. And then lastly, you can do an MRI or CT. An MRI or CT is more relevant if you suspect malignant changes, and it's a really good tool for monitoring. You also want to ask them to start something called avoiding diary. Not avoiding diary, avoiding diary. So how commonly are they going to the bathroom, what their symptoms are like, what their stream is like, how many times do you have to wake up at night, and so on. This is also really crucial for when we start treating BPH. One of our first things to do is conservative management, and that is going to include things like the diary, fluid restriction, and so on. So the PSA, now PSA is a very controversial test as you guys probably have heard of. Here is the official statement of when to use the PSA. So they say that consider ordering a PSA if prostate cancer is suspected in patients with a life expectancy greater than 10 years who are eligible for prostate cancer treatment. So let's break this down. PSA, as we know, is a screen test for cancer, right? Only do it if the patient is expected to live more than 10 years, because if, let's say, a patient's life expectancy is less than 5,
even if they do have cancer, our approach would not be particularly different. It would be watchful waiting and a conservative approach. And likewise, assessing if they are eligible for prostate cancer treatment. If they aren't going to be able to receive treatment because of any number of complications, you would not want to do a PSA because it won't help you much, right? It would only confuse you. PSA is not a routine test performed for lower urinary tract symptoms. So don't go around doing a PSA for every patient who you suspect has BPH. If you do order a PSA, a total PSA greater than 1.5 suggests gross enlargement, typical of BPH, while a PSA greater than 4 causes or suggests an increased likelihood of prostatic cancer. Now, the way PSA works is that the PSA just says that's a prostate-specific antigen, which means that all the PSA found in your body is made by the prostate. It is not prostate cancer specific. So just reiterating that, all prostatic cells, normal prostatic cells, make PSA. It's just that when you have too many cells, you can end up with too much PSA. And malignant cells often are out of control with their metabolic actions, which is why you would see a high PSA with cancer. As with most proteins, PSA can also be with most hormones, it can either be protein bound or free. Now, we looked at the total PSA, but we can also look at the free PSA as well as the ratio. Typical of prostate cancer changes is when you have a reduction in the free PSA, but increase in the total PSA. Now, we talked briefly about urodynamic studies, and this includes two broad things. Firstly, we have the post-voidal residual volume. Now, as I said, if you have an obstruction to the bladder and it takes a lot of pressure to open up that obstruction, obviously you're not going to be peeing out all of the urine, and there's going to be some that's left behind, because by the time you pee, let's say half of it out, you've lost that pressure and can no longer go. This would result in something called an increased post-voidal residual volume. That's a bit of a mouthful, but all it means is the amount of pee left in your bladder or the size of the bladder after you have gone to the bathroom. And anything above 50 ml is considered abnormal. The second aspect of urodynamics is uroflowmetry. And this is the test we actually do. It's a Doppler-based test, and we perform it while the patient is maturating to assess the maximum flow rate, or the fastest speed by which they can which they can empty urine. And obviously that is going to be lower in patients with bladder outlet obstruction, which again would be typically seen with BPH. Now, in terms of treatment, there are three approaches we can take. First is our non-pharmacological conservative. Next, we have pharmacological, and lastly, we have surgical. What to do depends on their severity of symptoms and how greatly it's impacting their life, which is why it's good to assess the frequency of their symptoms, which all fits in with their diary. If they have no symptoms or little symptoms that aren't really bothering them, we can go for conservative methods. So have a bladder diary, bladder retraining, as well as fluid restriction to about 1 to 1.5 liters of fluid a day. If they have considerable symptoms, we would firstly start with pharmacological therapy, and if that fails, move on to surgery. So we have a few medication classes we can use. We have alpha blockers, 5-alpha reductase inhibitors, antimuscarinic agents, and phosphodiesterase type 5 inhibitors. So let's talk a bit about how each one of these work. Firstly, we have our alpha blockers. These block the alpha receptors, which, as you know, cause relaxation of the bladder neck and urethra. A good example is tamsulosin. You also need to know that alpha blockers are potent hypotensive medications, which means that they're quite commonly used with hypertension, and that's one of the complications you would worry about. If a patient has tendencies for hypos or has orthostatic hypotension, you might be a bit more cautious about giving them an alpha blocker, because you know that increase the risk of hypertensive episodes and the risk of falls. Next, we have 5-alpha reductase inhibitors. Now, as we talked about, the major aspect of prostatic hyperplasia is hormonal. And the hormone that's responsible is DHT, or dihydrotestosterone. DHT is produced from testosterone by the action of 5-alpha reductase. So, as you can imagine, if we block 5-alpha reductase, we would produce less DHT without necessarily affecting testosterone levels. It's also used for male pattern baldness because DHT is the same hormone that has a role in androgenic alopecia, or male pattern baldness. Important side effects you need to consider: erectile dysfunction, decreased libido, as well as gynecomastia. Important examples include finasteride and deuteriside. Finasteride is the one that's typically used for male pattern baldness. Next, we have antimuscarinic agents, which relaxes muscular tone. So I think that makes sense. The muscarinic agents would increase tone, and antimuscarinics would do the exact opposite, and that would cause symptomatic relief. A common example is oxybutynin. And lastly, we have phosphodiesterase type 5 inhibitors, which again reduce muscular tone, but this time of the detrusor muscle of the bladder. And a good example of that is tadalafil. Lastly, we have surgical treatment, and the gold standard at the moment is TURP, or a transurethral resection of the prostate. Some complications you need to know about TURPs. I've split them up into early and late. So early complications are ones either perioperatively or the ones post-op early on, including things like bleeding, acute urinary retention, if you damage the urethra in the short term, UTIs, another big one, because obviously you have an invasive procedure. Later down the track, you can have things like sexual dysfunction, present in up to 35% of patients, strictures in the urethra, this phenomenon called retrograde ejaculation, and you may have recurrent BPH. So that's another thing you need to worry about. And that's all we had for BPH. Thank you guys for coming. We will be picking this up in our next lecture on prostate cancer, where we'll be reflecting on a lot of the things we've learned today. So as always, if you have any questions, please feel free to send me a message. And as always, please look after yourself and please look after your loved ones.